we went through the technique on Tuesday about how to actually, what the whole process looks like, but I kept asking some groups, where might you stand? Where might you be? Not saying you have to know where that is, but just starting to think about it. So if we're gonna do, we're gonna do the walk around, so we'll start, for ease, how about we start in prone? That's the way the picture says it. Okay, so I might want to have Billy pick a side he wants to go to, and then my goal is to not be in the way. So if he's walking to the right, I'd like to be on the left a little bit, so I don't kind of block that if I can do that. If I need to be on that side, then I'm on that side. So, okay. So if he's first learning this and I have to kind of help him unweight, I could be kind of up here and do this. So I'm going to have you go ahead and go up on your elbows. Go ahead, up, up, up. Good. And then when I think about sensate areas, if I'm going to give any kind of cues or tapping, it's going to be somewhere where I know he's innervated. Me tapping on the trunk does absolutely no good. Me tapping at the leg, if I'm not telling him I'm doing that, will do kind of nothing. So if I'm going to go, I want you to go ahead and walk over towards your hip. Good. Walk, 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 walk. Good. Walk. And he gets to a point when either his legs start to pivot, like for example, if he doesn't have a lot of flexibility, and I have to decide how to help. So here I need him to get to a point where he can get in front of his hip. So for Billy, because either he's got tightness here or his arms are a little bit shorter, what can I do to kind of help him get a little bit more length, or artificially lengthen to kind of compensate for the flexibility? I talked to some groups about this.
Loops?
Could do something, well, it could do something like elevate the surface a little bit potentially. So could I just temporarily have like one of those blocks if I need it?
You can.
Okay. Thanks. Okay, so let's see how much farther he can go. Okay, keep going. You can go a little bit farther. Good. And we're starting to get to the point where he needs to be. So I'm going to tell him, I need you to walk your elbows in a little bit closer towards his hip. Walk, walk, good. Walk, 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 walk. And so as he starts to walk back, what's happening to his hip? Yeah. So has he dropped enough? Probably not. So I'm going to say, could I do anything to kind of get him to push and like do that protraction piece? Good. If he's not getting enough here, what could I use? What compensation strategy could I use besides either putting a block here or helping push up? What's like a compensation that we could do?
A loop with pull.
Think of something that he has that he can use, a strategy that he could use. So when we did rolling and we used like a little bit of momentum, yeah. So can he do a little pushing and rocking? Good. So he could rock. He could do something like this. Now, if I went to just help with his hip, and I said I'm going to push your hip down, would he be able to feel that or help? Probably not. But I might have to temporarily kind of do that. I could show him a mirror to say, like, this is what I want your hip to do. Can you feel your hip coming down? If I wanted to, just temporarily come up. If I wanted to kind of use something, make it a little bit taller for him, if I could push here, so try to get him to push and really kind of rock, so he's going to kind of push his elbows down into the mat, trying to get this hip to come down. And once he gets to a point, I might hold him here and tell him, can you go ahead and hook underneath here? Good. And I'm going to tell him to stay low, so I'm going to help keep his head down here. And you might need to do head hip, so kind of doing a little bit of momentum to bring him over. Good. And then from here, I'm going to be kind of behind him, because the one fear he would have, he would fall backwards. So I'd like to, where I end up is going to be in the back to kind of help him. So I've kind of walked around with him, so he ends up kind of here.
So let's have her stop there. What are the things he can practice in pieces to get ready? We're trying to start to put that all together. Walking on elbows. Going as far as he can, coming back, going both ways. And it's a great way to start to get that flexibility. What else? Maybe in that position with elbow down and just working the hip down, up, protraction, drop the hip, up a zillion times. And we could have gotten there from starting in long sit, right? We wouldn't have even had to have worked our way up, but we can start up and work down. What else? Hook. Practice hooking and pull. And we'll also practice in how do we get that elbow extension, because the one case I showed you in class, he clearly got a push up off that arm without triceps. So how does he get that? So practicing that piece of locking out that elbow. How do I lock out that elbow? We'll get to that a little more. Okay. But I will say, for a lot of patients, I really work the two ends. I will be practicing elbow walking a lot, and I'll be practicing going from upright to where do my elbows need to be, to coming back up to upright to where do my elbows need to be, to practicing dropping the hip, practice walking down again before I actually start all the way down to come up. Just so that they kind of learn where that position is. Because when we say walk past the hip now, how many of you couldn't tell if you had walked past the hip? And you have proprioception and can see. So sometimes working from up down, if I get my elbows down and I don't fall over backwards, it's probably the right place. If I fall over backwards, didn't go far enough. And yet you keep them safe.
For necessary skill prerequisites, I would start by doing a lot of activities and supine on elbows. So, okay. And if it means I need to assist him at this point into that position, most likely I would, because we're just starting the training in this activity, I will. So just as we mentioned with proline elbows, supine elbows, elbow push-ups, and back down again. Okay, push away from my hand, or push up into my hand. I would do a lot of rhythmic stabilization, other P&F techniques for strengthening. I would have an elbow walk right and left. Is that about as far as you can go? You be a stiff little cookie. There you go.
So again, that functional stretching. I mean, we do give people stretching programs, but especially in the thorax, functional stretching.
We want to stretch the intercostal muscles to preserve good deep breathing and costal expansion. So this is a nice way to passively get at that activity a bit. Also gives me an idea if he has enough thoracolumbar lateral flexion in each direction to do the activity that Natalie just did prior that needs that type of activity also, okay? Then the higher skill set would be the ability to weight shift over one arm and unweight the other, okay? So I will likely need to help Billy initially. So Billy, we're going to go in that direction. So you see your companion there with the hat on? Mm-hmm. Okay. I want your hand eventually to try to tap the brim of that hat. Okay? Ready? Okay. And come up. And back down again. Okay, this is what we're looking for. Let's try it again. I want you to feel what our goal is. Okay. Ready? Up and reach. Okay. So two things we need to work on. First of all, strengthen the left shoulder girdle. All right? So when the arm comes forward and reaches forward, this shoulder will tip backwards, and just the reverse. All right? The other thing is momentum. With other activities we did, like rolling, you realize that the faster you move that arm and build momentum, the better it is for the task you're trying to perform. All right? The other thing is head. I want you to duck and dip your head to start to help that momentum. Okay? Should we put all three things together right away? Because you're
sure.
Good luck. Ready?
Okay.
1, 2, 3, and reach. Reach, reach. Okay. And come back and support. Okay. And again, up and reach. And come back. Ready?
Yep.
And again, up and reach. Now only go back part way and reach. Only go back part way and reach. Are you starting to feel how you're able to control your trunk movements through your shoulder?
Yes.
Okay, and now come back. And then we do the same thing on the other side.
So think about it. But the first time when he really throws and goes and really uses a lot of momentum, it helps him get that piece over. But on the other side, it's also training the posterior muscles of the weight-bearing arm to say, hey, learn how to recruit quick to stop, right? Although, and then as you get more graded control, but he has to learn how to, if we only move slow, only the slow twitch muscles are going to be engaged. And part of balance control involves some of the fast twitch muscles too. So it's not just momentum for momentum's sake. It's momentum for momentum's sake, but there is a secondary effect. And the downside of that is if he really throws and he's not quick enough yet or doesn't have that, you need to be ready to do what? Catch him, right? Because he may well throw and go, and then it's like, uh-oh, and he's gone. So think about those things.
Okay, I'm going to just do the next phase of it. Yeah. And I must admit, we talk about catching our patient and guarding our patient, and indeed we need to, but sometimes I let them go. I'll let them fall. They need to know what it feels like and that they're not going to hurt themselves. I remember the first time I was working with a C-spine patient in balance and short sitting, and his parents were down to observe. And this particular time, I just let him go and fall, and his mother just broke out in tears, going, "What's going on? What's going on with my baby?" It's like he needs to know that he has control over these activities, and the activities he doesn't have control over, he's going to know which ones will put him in danger and which ones will not. Okay, so back on your elbows. Okay, Billy, that was good. Now, we need to work on getting this arm propped behind you, because that is the next transition to get you into long sitting. All right? So this time, I want you to reach, duck and reach. Now this time around, this arm is going to swing all the way back, 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 back. Okay? So let's practice that. And whip it back. And forward. And whip it back. And forward. Good job. Next time you're going to whip it back, and you're going to whip bear through that arm. Ready? 1, 2, 3, whip it back, and now move the other arm back. Now I've already worked on the physical prerequisites to successfully achieve this task. So when we think of range of motion, what type of range of motion does he need in the shoulder, or both shoulders? When we talk about strength, what muscles would I be strengthening? Posterior deltoid, for one, to be able to whip back. And once again, momentum. He probably doesn't have sufficient strength in his shoulder girdle muscle to lift and place the arm back here. If he did, we wouldn't be going through all of these other activities initially, okay? So he really needs to use momentum and whip or swing that arm back. And so he needs to really have strength in the posterior deltoid to initiate that task.
I know I spoke to a lot of people. You figured out that, but I can get my elbow lock if I protract, which is true. You statically can do that and statically load. The problem with using protraction with your hand behind you is it doesn't translate to the dynamic activities. Because the minute you have to catch yourself here, so more out to the side, if you try to use protraction, you may not be able to get the elbow locked. Whereas if you've learned how to dynamically bend and straighten that elbow using anterior musculature, wherever that hand starts to land, they can learn to use that. And though we're talking about starting in severe external rotation, over time they'll get closer and closer and closer to neutral. And you'll see some people in the videos on Friday that are clearly like that. So moving forward, pre-transfer and level surface transfers. That's how far we're going to get today. We didn't intend to get any further than that today. So we'll do some demo of that. So head hip activities, and then a basic transfers 6 and 7.
Was head hips covered in lecture?
The definition of head hips was covered in lecture.
Okay. So at the first lab, you mentioned that one of the strategies individuals use for substitution of muscles that are not innervated is the head hip strategy. And we're going to review that today and put it into action. All right? So I need somebody on the mat.
So I'm seeing somebody initially. I want to talk about seeing someone who has, let's say, and we want to work on sitting activities. One of the first things I want to do is prop sitting. That idea of how to use my arms. If they have triceps, not so bad. It's not so hard for me to get them to learn to use the triceps. Then it's just a matter of teaching them how to place their arms. But if they don't have triceps, I want to use that concept of distal and fixed. Okay? So I'm going to swipe Natalie and have her kneel behind because I can't. I can on one leg, sort of, but not very well yet. Okay. So I usually am either behind, or I might sometimes start to the side, because this person does not have independent sitting balance yet. Okay. So what do I do currently as a therapist with bum knees? I have my aid kneel behind, and I'm at the side. Okay. And what we're going to do is we're going to learn where to put this hand and how to get it there. So there's a couple of steps. One, she's got to learn to protect her fingers. So we talked about already in bed, and so she might be leaning back against me if she needs to, or I'm going to hold her up here. We talked about, we're going to use this motion at your wrist to kind of be able to grab something. So that when you bring your wrist like this, your fingers close, And then when you do this, they let go, okay? But if I want to do that, I don't want to get my fingers stretched. I don't ever want to put open hand with fingers out, because then that'll stretch that and I'll lose my grip, okay? So we're going to work on getting your hands like this, okay? Getting them behind you. But because you don't have feeling, it's a little hard to know, are your fingers closed or not? So we're going to start with, how do I know where my hand is when I can't see it behind me? And so we're going to practice, and I'll support you. But what I'm going to have you do is literally, you're going to throw your hand back, but like this, so that you drag on the back of your hand. Okay? You're going to throw it back there and land on this. And I'll support them. There's C6. Where do they have sensation? In the lower hand. The thumb, right? So they may well catch that piece of it as they're coming down. So they'll know, yep, I've landed on at least, I feel some on the tip of my thumb, I can feel some of that as they come back. Okay. So that's the first thing. How do I position my arm? And I'll work on doing it with both sides until they've gotten this. And then I'll literally put them there. Can you feel this? And with their elbows locked out, I haven't even taught them how to lock it. They're just stacking, right? Natalie's coming in, doing approximation. Look, you're here. You're not going to fall over. Do you see that? They'll hold you up. Okay. And then I want to teach her, how do I teach her to let go at the elbow and come back up? And if you can't see her, I want you to first see how much wrist extension range she needs. So I'm going to have you just bend your wrist, or bend your elbow. So when she bends her elbow, and for those of you who can't see her well, if I bend my elbow, look at how much wrist extension range I need. I need a lot. I need more than 90 degrees if I'm going to use my elbow bit. So don't be surprised. You don't have to work some flexibility here as well. Okay. Now, I'm going to teach you, you used to straighten out your elbows with this muscle. Okay. That muscle isn't working right now. So we're going to learn how to straighten your elbow and then put weight on it, but we're going to straighten it with the front of the arm muscles. Okay? Because when they fire, they kind of pull this arm forward and get it. Now, it's not your shoulder that's going to come forward, it's the arm bone. Okay? And that's exactly what the patients want to do. They want to do protraction. And let's face it, if you do protraction and lean, the elbow's locked. The problem is you can't do any graded control. So, here are the rules. We're going to first work on where we position your hand. So Natalie's going to support her completely. I'm going to take this hand. I'm going to put your hand not only back, but turned back. Okay, and we all talk about why do we want it in that position?
That's okay.
Why do we want it in external rotation to start with? It maximizes the ability of anterior deltoid and clavicular pec, that when they fire, that elbow will come. Okay? If you're in internal rotation, it's already in a shortened position, it's a lot harder. That's not to say, and you'll see videos of people who get to kind of a neutral position eventually, but we start in external rotation. It's the easiest. Okay? And next what I'm going to do is teach her how to lock and unlock. So I'm going to take it through the thing. I don't want the protraction. I want that. I'm going to pull it in. It's like you're going to, so the elbow is kind of going through an arc of motion. Okay? It's extending, but it's extending by pulling here. Okay? So I might say something like, can you squish my hand? Squish my hand. Squish my hand. Because it has an adduction component and a forward flexion. Another cue is, your hand is stuck, but pretend you're bowling. Pretend you're bowling. You're going to bowl through the surface. But what I see, and we're going to unlock it, and come in, and unlock it, and come in. If she's protracting, you've got to do something to kind of say, no, not here. I don't want motion here at the shoulder. I want the motion on the arm bone. On the arm bone. Some people will do some tapping. It's right in here that I want. But when I tap, do you see what she does? She protracts. It didn't work very well for her. I can try tapping more on the deltoid. That helps a little bit, not as much as don't move this, let the elbow come. Make that a little easier. So I would do it on one side, I do it on the other side, then I'm gonna get to the point where, okay, you're gonna unlock both elbows, and now it's tighten up. Unlock them and come up. And unlock them, and I would be right where Natalie is, right behind. And then I'm gonna play with this in different positions. So we started with it way behind the next turn rotation. Can we do it with you right here? So more even, okay? And go. Okay. Okay. Locking out elbows. Then we're going to work on, okay, now that you know how to walk, do that, can you walk forward with your hands? So you're going to weight shift and move one hand forward than the other. So you're going to walk forward.
Keeping them straight, almost straight.
Yep. Good, and walk back. Way back, way back, way back. Good, and walk forward, and walk back a zillion times. We can work on locking out an elbow and reaching. So now you think of all the things we can do in sitting balance as they learn to do that. What could really screw them up if this is what you want them to learn? What if they have an elbow flexion contracture? They're screwed. I mean, you really need that elbow, you need full range. Those who hyperextend, I think it's even a little easier for them to find that position, but they have to have full elbow extension so that they get a lockout rest position. Otherwise, these muscles are going to be firing all the time, and that's not sustainable. Okay. Wrist range makes a difference too. So if I have somebody that doesn't have a lot of wrist extension, I have a tendency to take like half-pound weights, roll them up a little bit, and put them under the heel of her hand. So now you can weight bear on that. So now I don't need as much elbow extension, or excuse me, wrist extension. But I have to work a little harder here. But at least I can make up for it until I get that stretched out. And for some of you, usually that's where people complain during this lab right now. It's going to be the wrist. Now I don't have the wrist extension range. My wrist hurts. I'm hurting my wrist. You know, we can put something under the heel of your hand a little bit to get that up so that you don't quite kill it until I get that range.
At the other lab, some of the individuals said, well, what activities do you work on first when a person comes down to the gym? Tolerance to upright, of course, and we just discussed that, and balance. Okay, I can always start with balance. If the individual has difficulties with shoulder or neck pain, or is an immobilizer, or is extremely weak, or even has a certain amount of tightness that precludes them from doing perhaps what you just did now, I can still work on some balance activities. Okay? And that involves improving their tolerance to upright and their endurance, which will take us to all the other activities we practiced at the last level. So I'm going to have you turn around for the camera, I guess. Smile. All right. So with mat activities, I most likely when it comes to balance, sitting balance activities, still long sitting. Okay? If she has tight hamstrings, and most likely she does, okay, I can start by placing her in a ring sit position. So if you'd assume that, okay. Or I can have her legs somewhat extended and would roll towels or a pillow under her knee to allow a certain amount of knee flexion. Hopefully the therapist that was working in the ICU did a really nice job of starting to stretch, and then the person acute care followed through with that. So my battle is half won along the way. There you go. So the first thing to do is work on static sitting balance. She's already doing arm prop. Boy, her acute care therapist did a nice job before she came to rehab. Or the other way she knows that she can sit and maintain balance is to bring her upper body center of mass forward of her hips, resting on that tight tissues of her low back. And you can hook your arms, just extension. You keep yourself from falling backwards. Some people hook on the outside. Some people will come on the inside of the hook. And that way she can rest her upper extremities from the arm prop position. Okay. First of all, we work on just static and hand placement. Okay, then we start to say, okay, let's add some challenge to this. So what I'd like you to do is, let's put your arms back in the arm prop position. Okay. Now, I want you to unweight one arm and reach forward. Okay, and come back. Okay, and the other arm. Now bring your arms forward. Okay, so we've got you leaning forward. Now, reach with one arm. So I'm changing trunk alignment and back down. And then the other. Okay, and now both. All right. So we start with a less challenging task, moving up to a more challenging task. Now, what I see this young woman doing is doing a good job using her trunk muscles. There, the slouch. There we go. Thank you very much. The other thing is when she lifts an arm, how is she going to maintain her balance? Okay. The one thing that we did not see is a lot of head and shoulder movement. So, let me see if you scoot over just a minute. So just see a person doing this, lifting one arm, and then the other, and then we're lifting both. Movement. Early on, it's almost overuse of head and shoulders to maintain balance. And then down the road, it's more of a controlled, smaller amplitude movements.
Do you remember in development how they started with head and locking up upper trunk and then had to learn to let go upper trunk? Well, that's kind of the strategy they're going back to, but they're not going to a full high guard, right? But they're still using that same, because that's what they have. The difference is that's all they're going to get. And so they really have to learn to use everything just from that.
So from here, I may have an assistant behind her for safety. I may be in front.
You're just spotting.
So different ways to challenge balance. After we've done the one arm, two arm, both arm lift. Okay. I might do a gentle ball toss to her. Okay. Now she's not you.
You don't have fingers.
Sorry, yeah. Okay. Got it. Got it.
Yes.
Yes.
That is.
Okay. Or she may bat it back to me. And if she bats it, I might start moving at speed. Come on, let's bat it back. Go, 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 go. You I have on occasion dangled a balloon on a string that I've been able to secure to the ceiling and have them just practice batting a balloon if a ball is just too much activity for them. Okay.
How is her elbow extended? C6. Gravity. Gravity. Right. And where is the punch coming from? Shoulder girdle. Yeah, serratus. Here you go.
Thanks. I could hurt it. Okay. Nice trunk.
Yeah. Where's my hands from? Am I supposed to be left or right? Okay.
So you're going to use your arm prop to catch yourself.
Okay.
Okay?
Yeah.
No, you go back.
Okay.
You have to go
Forward.
swimming.
Okay, come forward. If she comes forward, your arm goes forward.
Okay. Got it. Sorry.
So come forward and catch yourself. Oh, she doesn't
We're
know
really
what I
bad
am.
at
She doesn't know, I know.
Okay, in the back. Forward. Okay, and back. That's all right.
Sorry.
You're resembling a true patient, so this is good. So I may do forward backward movements. Okay. I may perturbate her side to side. I may perturbate her at an angle forward and back. Okay. I'll start with my manual contacts on her sensate area so she can basically feel me coming. But when she gets better at this, just as Natalie mentioned, I move to the insensate areas. I may start with the mirror in front so she can see me coming, and then later on I can take away that mirror.
So think about the whole progression. Sitting balance, long sit as she talked about. She talked about first just static balance, right? Placing, don't let me move you. All of those basic, you learn how to be where you are. Then it's self-preservation, right? Whether it be reaching, and what are they learning with that? What are they trying to learn with self-preservation?
To not fall over.
Well, to not fall over, and where is that limit when I have to catch myself? And it's different than it used to be, right? I used to be able to lean way over here before I'd have to catch myself. Now it's here. And because I have to use a lot of momentum to get there, if I don't learn where that is, so that's what they're learning. They're learning is where is that cone of stability? Where is my center of mass to a point where I'm going to have to catch myself? And then perturbation. So now we're perturbing her outside. We can start inside the basis support, but really what Barb was doing was outside. Can you get quicker? Feel more range? Can you figure out that this time I had to catch myself, but this time I didn't?
I want you to do short sitting.
Okay? That's the progression we're going through.
I can do all of these activities in short sitting also. I generally start in long sitting because with the leg position we can create a basis support. In short sitting, that basis support is much smaller. The other thing, the fear of falling forward off the mat is a real fear of your individuals. So stay, early on when you're working with your individuals on the mat, I stay really close. I'm on a stool and I'm right here. Okay? So they can't go anywhere. And if I feel she's going to go backwards and I can't catch her, I might have an aide behind me. Or behind you, for that matter. But we can do the same activities, okay? And once again, you have that slouchy position. Okay. All right. Now, with one hand, reach, touch me. Okay, good, and back. And now the other. Okay. Now both. You got it. The jello up about it. Okay. Okay. Now diagonally, reach for me, and the other side. Okay. I may, as we did before with perturbation, placing it forward, backward. I can do this in short sitting also. Forward, catch yourself back, and forward, and back. Kind of call this salt and pepper. Because if she loses her balance, it is much more to her advantage to catch herself on propped arms than to fall backwards and try to figure out what she's going to do from that standpoint. It's short or long sitting. Okay? So the faster she can respond to a balance challenge, the more likely she's going to succeed with any transitional movement activity or functional activity that she's about to perform. Okay. Also, the better she gets with balance, the better she's going to be using that dynamic balance skill in transfer activities. I move between short and long sitting. If I'm working with a person who's just initiating rehab and my concern is upright to tolerance, or tolerance to upright, I may do a transfer onto the mat and work in short sitting for a little bit. When I start to see her get a little peaked or she goes, oh, I need to lie down. We can lie down, I can do my stretching activities while she recovers, and then I can bring her up into long sitting and work balance activities more in long sitting. And as she's doing more activity and we get more muscle contraction and when she's a little bit better in control of the blood pressure, I may end up in short sitting again. So I work back and forth between that. And if she's really having problems with her blood pressure that day, after we lie down, it might be a good time to work on rolling skills. So, integrating a lot of the activities that we've been practicing in the last 2 labs. We use head-hip relationship in moving forwards and backwards. side to side, repositioning in the chair, side scooting on the edge of the mat or the bed. It's a very useful strategy to have a good grasp of, okay? So we're going to use it now in a boosting activity, okay? So she's going to be lifting her buttocks up in the air, all right? And we'll say C7, so we don't need to be concerned about positioning for triceps, all right? So C7, just lift your butt up. Okay. So, what do you think of that? Be kind to her, but what do you think of that? Okay, do you think we can do better? Oh, that's the answer. We know we can do better. Okay, so we're going to just start by using an exaggerated head-hip strategy. Okay, this time, when you lift up, I want you to drop your nose to your knees almost, okay?
Okay.
Really duck. Duck, 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 duck. Lift, 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 lift. And down. Better? Okay. Now, we talked about one of the obstacles that impedes some of our functional activities sometimes is arm to trunk ratio. Okay. If she had very long arms, we'd probably get a better boost. And she seems to have a good ratio, but I still want a better boost. So how can I cue her to place her hands to improve the length of the arm in proportion to the trunk ratio so that she can boost even higher? Forward, forward and in, okay? Okay, ready?
Yep.
And if you need to use a little momentum and do a couple, and duck, lift, 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 lift. Really nice. All right? So that's the benefit of head-hip. All right, we can use head-hip, I said, for lateral movement. And
Wait,
this-
before you go there, if she had to scale that down even further, how would she scale that down? Make it easier for the person.
She put something on the hands.
Could put her hands on blocks to make her arms artificially lower. Blocks or push-up blocks if she had grip. What could Barb do? Barb did it to a degree. Huh? Lift her more. Right. Going all the way to, okay, you go up and doing almost the whole lift and say, now hold it. So place and hold. You can still, don't forget, when you start scaling, you can go back to that same process of what's the lowest level task? Place and hold. I'm sorry.
Oh, that's all right. Okay. I'm just watching the time. That's right.
Yeah.
All right, so we talked about side-to-side movements also, which are going to transition nicely into slide board transfers or transfers without a slide board. But we'll practice them here on the mat. So she wants to move her buttocks to the right. Okay, what does she need to do with her head and shoulders? To the left. Okay. So right hand is going to be placed forward and out. You need some room for the pelvis to move. Left hand, to get as much length out of the arm as we can, is going to be at her hip and close to her body. Okay? So what you're going to do is you're going to duck down and boost, and you're going to rotate at the same time. Okay? When you're ready, 1, 2, 3, go. Nice. Okay? And to return, right hand back, left hand out. You're going to be rotating in this direction. You do your own count over. All right? So what we're looking for is hand placement. If she's moving to the right, she needs to have her right hand out and forward to help with balance. Also to provide enough space for her buttocks to move. Left hand close to her body, close to her hip. The farther she ducks down, hopefully the better boost we'll get. The more she flexes her head and takes up that passive tightness throughout her thoracolumbar spine, the better response we're going to get of the pelvis immediately moving. Okay.
And notice when she starts with her hands offset like that. So if you offset your hands like you have it, and your shoulders are lined up with your hands, what has that done to her body? It's not a trick question. It's twisted it, so that when she bends down and lifts up, the body will untwist to get the pelvis under the shoulders. So that asymmetry of hands is really important.
let's just have you go back and do one more boost at the very end. And now that you've been practicing your boosting, let's see if you can go even higher. Use any strategy that we've talked about or that you can think of, okay? And lift up. Nice, okay? Nice clearance. So this is something that might be useful down the road if she's on vacation and she's transferring from a low hotel bed to her wheelchair height. Or she's transferring into a car or somebody's SUV. These are the type of skills that can be employed with those higher level functional activities also. Should we,
What if she has tight hamstrings? And we just screw? The hard thing about ring sit is look what happens to your hands, though.
There's no way that's happening for me.
You just bolster them.
You want to answer?
Go ahead. I didn't hear it.
Could you just bolster the knee? Just like put a pillow or a bolster under it and do the same activity?
You could. But the other thing is you might go to short sitting. Do you want to do it in short sitting at all?
Well, yeah. We're going to do lateral scooting on the edge of the mat, which is a fine activity for working on both balance and strength and general mobility. So let's have you scoot to your left. Okay. So whereas left hand is going to be out and forward, right hand is going to be close to the hip. Okay, good. This time concentrate more on the lift. Okay. Right? And what I oftentimes I'll do for training, I might take like a towel roll. And I put it here and say, okay, boost up and over that towel roll, and you position it. Okay. Come back to the middle. And if she's doing this on her own, okay, do a boost and scoot to your right. Okay. Now is when you move one leg and then the other.
Okay.
Okay. Reposition. And scoot, boost again. Okay. So duck and boost might be the verbal cues I give.
Really do need to work on that. And yet you have to decide how much extension are we going to use, because you really create, I mean, think about what is normal range of the shoulder girdle according to whatever source you learned way back last year. 60 degrees. So if you decide that, yes, I'm going to, we used to, Barb, correct me if I'm wrong, stretch everybody as close as we could to 90 and beyond in shoulder extension. And the downside of really stretching someone is as you get more range, with a joint, the configuration that the glenohumeral joint is, you better do a whole lot of strengthening. And in our patients who aren't fully innervated, we set a lot of people up for shoulder issues. So there's that trade-off. How much range do I need for this particular person? What are options if I don't go all the way there? Are they going to be functional or are they not? And you probably have...
In the ICU, their general medical well-being is of paramount importance, so we come in a distant second oftentimes with that. But what I try to do is get an assessment of the individual's sensory and motor level. I might not be 100% accurate. I can't be. You know, the patient's in and out of alert level of alertness. Pain is an issue. Doctors, nurses are coming in. Noise from the machinery, often limited by lines and tubing. But what I want to do is get an initial assessment of, like I said, at least what level, motor and sensory they are. We as PTs see these individuals one, sometimes twice a day in the ICU. We probably have our hands on them in an assessment capacity more than any other person, including the residents and the physician. So if there's going to be a change in their status, i.e. my main concern is an ascending level of lesion due to edema or a bleed, we're oftentimes the ones that are going to notice that before another person will. So every time I go into the ICU, I just check that level, and that can be done quickly. Okay. Otherwise, I'm involved in treatment. My main goal is stretching, gentle stretching at that time. If they have had cervical stabilization, most often your facility will has a protocol as to how far in abduction and flexion you can stretch that person. Safest is to end at 90, to stretch to 90. 120 oftentimes is some physicians will give you that leeway. At the pelvis, I also stretch the hamstrings. Once again, if they're a low level, 45. If they're a higher level, para, 65, 70. Oftentimes we can't go to 90 initially. At the quad level, we certainly can, but at the para level, not so much. And when I check with the physician as to how far I can stretch this individual, I don't say, I'd like to stretch their hamstrings, is that okay? I say, I would like to lift their legs straight up in the air to 60 degrees. Is that okay? I'm very specific in what I ask. And then in the note for that day, I document that I was cleared to do this activity. But otherwise, I'm thinking ahead when this person is in the clinic and on the mat, and we start some of the activities we've done so far this week. Do they have the necessary physical prerequisite of adequate range of motion and flexibility? So I'm thinking ahead. Okay. So let's talk about that a little bit. At the shoulders, eventually, when a person's an active participant in rehab, what type of range of motion would I like to see in the shoulder? And as Judy said, if they're going to do an activity such as what we've been practicing today and they need like hyperextension, at that point I'll start working on that activity. But right now I want full range of motion. Okay? My concern is the two joint muscles. Okay? We oftentimes see stretching of the wrist. The arm is, a person's lying in their hospital bed and a therapist, OT or PT, will come in and range this way. You know, my concern is those wrist extensors are two joint muscles. They cross over the elbow too. And later on, that person's going to need to be able to arm prop on the mat with extended elbow. So when I range wrist, I range with elbow extended. Okay. Biceps is a two joint muscle. Okay. I don't range biceps with arm at side. I range biceps with arm up to the side or slightly overhead, given the limitations I may have post-op. If I had the arms out like this, my family says, what can I do while I'm in the ICU visiting my family member? I say, if cleared by the nurses, just place their arms like this, okay? Or a little bit higher. Simple task. I'll start, so we talked about range of motion, I start strengthening. But usually it's either isometric strengthening, active range of motion, or very gentle passive. Because oftentimes we need to be concerned about intracranial pressures and blood pressure, so asking them to do forceful activities may be not what's indicated at this time. I can start working on tolerance to upright minimally. Raising the head of the bed up. We know when we work on tolerance to upright, that's the first activity we do bedside, is raising the head of the bed up. And then secondarily, we swing the feet over the edge of the bed. In an ICU, we can just do the first part of that activity. And patient education. Start talking to the patient and their family. Find out, I don't do so much in the way of, you've just had a C6 spinal cord injury. What this means is you're going to have radial wrist extensors and do this but not do that, but rather generally how your life is going to change. How do you perceive things are going to look a week from now, a month from now? Get a feel for the family support that they have, because that's going to be so important later on. And you don't have to ask direct questions. Find out what their interests are, because later on, if we're working on balance activities, and they like to play tennis or golf or volleyball, I'm going to use that. When you play those activities in an arm swing and that momentum, we're going to use that right here. So I try to integrate some of their interests into mat activities.
So average length of stay in an ICU setting, I think the average is 3 to 5 days. So it's not all that long. And after 3 to 5 days, they're going to be coming down. Or maybe still sit in acute care. There's some, depending on the hospital, there's some actually very wide differences between what happens. And they often come down in a Cadillac chair first. You want to talk about Cadillac chairs?
The cardiac chair?
The cardiac chair.
Okay. There is a chair, an oversized Cadillac cardiac chair you may have seen in your fills. It's an upholstered chair. You crank it from behind and it lies perfectly flat. And then from behind you crank it up again And as the head comes up, the feet drop down. It's super wide. Have you seen those? It's a one-size-fits-all, which means it fits nobody. It is one of the easiest chairs to transfer into for the nursing staff, because they can use a body slide board and slide a person onto it and then crank them slowly up to sitting. I really don't like these chairs. I've been known to, in my younger days, to take the chair and wheel it down to the next unit so the nurses can't find it on their unit. They keep saying, this chair keeps disappearing. It keeps ending on B64. They don't need it. Where does it get? And the reason for that, if you've had your lecture on tolerance to upright, we know we want to play with that idea of bringing the head up or dropping the feet down. Maybe we want the head up but the feet up, or up also. Or maybe we want to just slowly start lowering the chair. And in those cardiac chairs, you have no choice. So it's an all-or-one type of a technique for tolerance to upright. The second thing, it doesn't fit anybody. They're too wide, and you know it because when the person comes down to the clinic, the nurses have 7 or 8 pillows stuffed on either side and under their legs and under their head and on top of their arms, because even the armrests aren't you can't adjust. They're not at the right height for most of these. And then the other thing is, because you're not sitting properly in the chair, most often these individuals come down sitting in a posterior pelvic tilt. They're sliding. Okay? So first of all, for trunk alignment, that's terrible. For head and shoulder, that's terrible. For skin, it's more than terrible. So if I had my druthers, well, the next option would be a standard reclining wheelchair, manual reclining wheelchair that's oftentimes used in orthopedics for your shoulder patients. At least you can independently move segments of that chair to adjust to tolerance to upright and have a little bit more say in positioning. But if I had my druthers, I would have the tilt and space chair. Have you had that equipment? Okay. So tilt and space chair, as you know, allows the hips to remain at a 90-degree angle. And then you can tilt the chair back and forward. And if it has elevating leg rests, you can independently control leg alignment in proportion to the rest of the body. So that's the one I like the best. Amen.